Good evening, doctors. I have some questions regarding Pap smear.
Sure, please have a seat.
What is the history of Pap smear?
So, let's start with talking about the inventor. George Nicholas Papanicolaou was a pioneer in elucidating the physiology and cytologic characters of the female reproductive system. He was a more enthusiastic scientist who obtained a Doctor of Philosophy degree in zoology at the University of Munich. When he began work on sex determination using guinea pigs, he was faced with the problem of being unable to determine the time of ovulation without sacrificing the animal. This led his microscopic examination of material be obtained from the vaginal canal of a guinea pig. In 1916, he deduced that the reproductive cycle in the experimental animals could be timed by examining smears of their vaginal secretions. And those first slides relieved an impressive array of diverse cell types and patterns. His initial studies of both guinea pigs and humans, first published in 1917, documented in detail the different cytological vaginal patterns associated with physiological changes. The first data to suggest that the cytology had value as a test in the early detection of cancer came from Papanicolaou's discovery of cancer cells in the vaginal samples from a hospital volunteer. From 1920, he began to focus on the cytopathology of the human reproductive system. And he was thrilled when he was able to discern differences between the cytology of normal versus malignant cervical cells upon a simple viewing of swabs smeared in microscopic slides.
In collaboration with Dr. Herbert Trout, a gynecological pathologist, eventually publishing their landmark book in 1943, Diagnosis of Uterine Cancer by the Vaginal Smear. It described physiological changes of the menstrual cycle and the influence of hormones and malignancy on vaginal cytology. Introduction of the Pap test in the clinical settings faced major challenges both in Canada and the United States. The discipline of cytology was in its infancy. Cytology laboratories were very rare until the later part of the 1950s, and pathologists were just beginning to accept the concept of cytological diagnosis. Cervical vaginal screening increased greatly in the 1950s, when the cancer societies in Canada and the United States endorsed the Pap test as an effective cancer prevention test and promoted it in their campaigns. The oral contraceptives was introduced in the next decade, and annual Pap test became linked to family planning.
Who needs a Pap smear?
Since you asked, let me tell you. A Pap smear or a Pap test is a screening procedure of cervical cancer. It tests for the presence of precancerous or cancerous cells in the cervix, which is the lower part of the uterus. The main purpose of Pap smear is to detect and identify cellular changes in the cervix such as atypia and dysplasia. Pap test is one of the great success stories in early detection. A swab of the cervix can reveal abnormal cells often before cancer appears. How often should females get this test? Females starting from age 21-year-old should get this test every 3 years. Females over 30-year-old can get this test every 5 years if they have previous normal Pap smear and HPV test results. Females over 65-year-old can stop having this test in the future if they have a history of normal Pap smear results. Pap smear is recommended frequently in females with increased risk for cancer or infection, in females testing HIV positive, and in immunosuppressed females due to chemotherapy, organ transplantation, cortisol medications, etc. So as we said, females from age 21 to 29 get this test every 3 years. Females from age 30 to 65 get this test every 5 years if they have previous normal Pap test and HPV test results. Females above age 65 may stop having this test if they have a history of normal Pap test results. Most cervical cancers are due to infection from human papillomavirus, HPV, which is a sexually transmitted disease. Did you know that there are 100 types of HPV? Well, now you know. These types are classified into low and high risk types according to the possibility of causing cancer. How do you get HPV? If two persons having sexual intercourse, the male partner is infected with HPV, then the female partner could get HPV infection. Most HPV infections are transient, so they are eliminated within months by the host immune response. HPV types 6 and 11, which are low-risk types, are responsible for condylomas and genital warts. HPV types 16 and 18, which are high-risk types, are responsible for 70% of cervical cancer cases. HPV causes cervical cancer within 20 years. The normal cervical epithelium undergoes dysplasia to progress into cervical intraepithelial neoplasia 1, which is called CIN1. This may progress into CIN2, then into CIN3, and eventually into cervical cancer. Okay, let's move on to indications. Pap smear is used in clinical suspicion. It's estimated to reduce cervical cancer incidence and knowing the stages of cervical cancer. When diagnosed early, cervical cancer is highly curable. When cervical cells first become abnormal, there are rarely any warning signs. As the cancer progresses, symptoms may include unusual vaginal discharge, vaginal bleeding between periods, bleeding after menopause, and bleeding or pain during sex, which is called dyspareunia. Pap smear is also used before the insertion of an intrauterine device, IUD, because having an existing infection, insertion of the IUD may spread it, making women at slightly higher risk of pelvic inflammatory disease, PID, for a few weeks after the IUD is inserted. Finally, early treatment of precancerous changes and cervical dysplasia detected on the Pap smear can stop cervical cancer.
What is the procedure of a pap smear?
The test takes only a few minutes. You may be asked to undress completely or only from the waist down. You will lie down in your back on an exam table with your knees bent. Your heels rest in support called stirrups. I will gently insert an instrument called a speculum into your vagina. The speculum holds the walls of your vagina apart so that I can easily see your cervix. Inserting the speculum may cause a sensation of pressure in your pelvic area. I will take samples of your cervical cells using a soft brush and a flat scrubbing device called a spatula. This usually doesn't hurt. I will place the cells in a petri dish and send it to a lab for tasting. And here is a video demonstrating the procedure.
To make a cervical smear, you will lie on an examination table with a bare lower body. The assistant will need a speculum to perform the cervical smear examination. Before the examination, the speculum will be brought to body temperature by warming it with warm water. Then it is brought into the vagina and the speculum is opened. The walls of the vagina are spread and the cervix becomes visible. The assistant uses a brush to remove some cells from the wall of the cervix. The brush is put into the cervix through the speculum, where the cells are removed with circular movements. Mostly this examination does not hurt. You can have a slight sickly feeling when the speculum is put into the vagina and during brushing.
Then the sample is sent to the laboratory to be examined by microscope.
So what are the possible results of Pap smear? Possible results include normal bacterial vaginosis, chlamydia, HPV, and even more. So let me show you under the microscope. To begin with, we will talk about 4 normal cervical cells that can be seen under the microscope. First, here we see superficial cells that are derived from the outermost of the cervical epithelium and usually seen in the proliferative phase of menstrual cycle and in the presence of irritation. The nucleus is highly condensed, pycnotic, and the cytoplasm is abundant, eosinophilic. Keratohyaline granules may be found in the cytoplasm, reflecting elaboration of high molecular weight keratin protein. Secondly, this is a typical intermediate cell with a polygonal cytoplasm. Its nucleus have finely granular chromatin with a longitudinal groove. Cross-sectional area of intermediate nucleus is about 35 micrometers square and is used as an internal reference for its size comparison. The light can pass through the nucleus due to chromatin being more open than that of a superficial cell. Here we see parabasal cells that are usually seen before menarche or following menopause when the epithelium is not fully glyconated. They carry no significance other than being occasionally confused with dysplastic cells due to their immature appearance. They usually have oval nucleus, fine chromatin, and a cross-sectional area of 50 microsquare. The cytoplasm is dense relative to the intermediate cells. Lastly, transformation zone is the squamo-columnar junction where the stratified squamous epithelium of the ectocervix meets the endocervix glandular epithelium. The position of the transformation zone varies with age. The specimen is reported as either negative for intraepithelial lesions or malignancy. These specimens in which no epithelial abnormality is identified, or reported as epithelial cell abnormality is specified, including nuclear enlargement, presence of coliocytes, and increased nucleocytoplasmic ratio, and frequent mitosis. These abnormalities are associated with human papillomavirus infection and cervical precancer and cancer as defined by the Bethesda 2001-2014 classification. Squamous cell abnormalities which can be seen include: first, atypical squamous cells that are categorized as either of undetermined significance or cannot exclude a high-grade squamous intraepithelial lesion. Secondly, low-grade squamous intraepithelial lesion, which includes changes consistent with HPV infection and a possible histological finding of cervical intraepithelial neoplasia CIN1. Thirdly, a high-grade squamous intraepithelial lesion that includes changes consistent with HPV infection and a possible histological finding of CIN2 or 3. And lastly, squamous cell carcinoma. Glandular abnormalities include atypical glandular, endocervical, endometrial, not otherwise specified cells. Also atypical glandular, endocervical cells that favor neoplasia, and endocervical adenocarcinoma in situ. Here on the right we have atypical endocervical cells that show radiation atypia with enlarged nuclei, slight hyperchromasia, mild variation in size and shape, sheaths or strips with minimal nuclear overlapping. Most patients with only reactive changes due to inflammation will not have an organism identified in their cervical cytology test. The cervical cytology sampling does not need to be repeated unless the patient is HIV positive or has history of immunosuppression, in which case it should be repeated in 4 to 6 months. Hyperkeratosis or parakeratosis on otherwise negative cervical cytology test is not a marker for significant CIN and may be related to infection or trauma with inflammation. We don't perform colposcopy based on this finding. Instead, we repeat the cervical cytology test in 6 to 12 months if the patient is at increased risk for CIN, such as immunocompromised or age less than 30. If hyperkeratosis persists, treatment with topical estrogen may resolve the finding, but no treatment is necessary. In the cytology specimen, we will see a nucleate mature polygonal squamous cells with ghost-like nuclear holes. Here we see shift of normal flora to suggest bacterial vaginosis. Diagnosis is confirmed when at least 3 of these criteria are present: clue cells, which are characteristic and represent squamous cells covered with numerous coccobacilli, absence of lactobacilli, scanty neutrophils, profuse free coccobacilli scattered among chronified type epithelial cells, and response to empirical antibiotic therapy. In chlamydia trachomatis infection, aggregates of benign polymorphous lymphocytes with actual germinal center form, tangible body macrophages, and inflammatory cells are found. Capillary transversing lymphoid aggregates. Lesion may be mistaken for malignant lymphoma. The lymphoid cells may appear in cluster and may be mistaken for endometrial type cells. Trichomonas vaginalis is the most common parasitic infection of the female genital tract. It appears as small, beer-shaped organism with an eccentric nucleus and red cytoplasmic granules. It stains gray-blue with dirty, fuzzy background with aggregates of neutrophils, cannonballs. Reactive nuclear changes, perinuclear halos, and pseudoeosinophilia of the cytoplasm and the nucleus are seen. Leptothrix is associated with Trichomonas vaginalis in 80% of cases.
Next, we have choleucytosis. Choleucytosis is a characteristic lesion caused by human papillomavirus. It can cause benign squamous papillomas such as genital warts, and also causes HPV-associated cervical carcinomas. Approximately, there are 70 genetically distinct types of human papillomaviruses identified, with type 16 and 18 are in more than 90% cases of squamous cell carcinomas, and they are high risk for cancer. Choleucytic changes seen under the microscope as nuclear enlargement 2 to 3 times the normal size, wrinkled nuclear contours, and perinuclear cytoplasmic vacuolation. On the Pap smear, we can see mature squamous cell with enlarged nuclei and variable chromatin and nuclear membrane. Choleucytosis or perinuclear cavitation of the cytoplasm is characteristic for HPV. On the other hand, we can see nuclear molding, margination of chromatin, and ground glass nuclei composed of cytologic presentation of early HSV. Cytopathic effect of the virus may disrupt cervical squamous epithelium, stimulating squamous cell carcinoma. Precancerous cervical epithelial histologic changes are classified to either low-grade or high-grade squamous intraepithelial lesions. They are associated with high-risk HPV infection, especially 16 and 18. The diagnosis of SIL is based on identification of nuclear atypia characterized by nuclear enlargement, hyperchromasia, coarse chromatin granules, and variation in nuclear size and shape. The grading of SIL into low or high grade is based on the expansion of immature cell layer from its normal basal location. Low SIL is confined to the basal third of the epithelium. Cells can occur singly or in clusters. The overall cell size is large and fairly abundant mature, well-defined cytoplasm. There is a slight increase in nuclear cytoplasmic ratio. The nuclei are hyperchromatic and variable in size. On the left, you can clearly see that the upper two-thirds are still normal. On the right, we can high squamous intraepithelial lesion is when atypia extends to the full thickness of the epithelium. While overall cell size is variable, in general, the cells of high SIL are smaller than low SIL. Higher grade lesions often contain quite small basal cell type. Note there are no invasion of the basement membrane. It can also seen as a syncytial aggregates of dysplastic cells resulting in hyperchromatic crowded groups. Nuclear cytoplasmic ratio is higher in HSIL compared to LSIL, where it shows marked increase in nuclear cytoplasmic ratio. The choleucytic changes of coarsely granular chromatin and irregular contour of nuclear membrane are still present. HSIL are the direct precursors of squamous cell carcinoma. You can clearly see that there is a variation in nuclear size and shape, and cells have delicate cytoplasm. Note the nuclear cytoplasmic ratio. Notice the difference between low and high squamous intraepithelial lesions. Low SIL is only confined to the lower third of the epithelium, while HSIL extends to the full thickness. It's important to note that there is no invasion of the basement membrane. The cytology of cervical intraepithelial neoplasia as seen in Pap smear. A show normal superficial squamous cells. B show low SIL choleucytes. C shows carcinoma in situ, grade 2. D show high SIL or CIN3. Squamous cell carcinoma constitute 80% of all cervical cancer. Peak incidence of invasive cancer is at age 45. Routine Pap smear screening helps to detect cervical cancers at subclinical stages. On Pap smear, it presents as isolated single cells. There is marked variation in cell size and shape.
There is markedly variable nuclei, and usually dense and opaque. It's seen as caudate or spindle cells, associated with hyperkeratosis or parakeratosis. It can be either keratinized or non-keratinized. You can clearly see marked pleomorphism in cell size and shape. Note the cells look spindle, and some show keratinization.
What is the difference between Pap smear and DNA testing, and when to need each? There are differences in terms of sensitivity and specificity. Let me explain to you. HPV DNA test is used to check for high-risk HPV infection in women. In a simple way, HPV DNA test depends on the extraction of HPV DNA from a cellular sample from the site of infection. Lysis of the cell is required to release the viral DNA from the sample. After that, extraction of HPV DNA is done. Next, molecular methods for detection of HPV DNA take place. PCR is used in most target amplification methods to detect and quantitate the presence of HPV. What are the indications for HPV DNA test? For a woman having certain type of abnormal Pap smear, or along with the Pap smear, it's called co-testing to screen women aged 30 and older for cervical cancer. Keep in mind that HPV DNA test is highly sensitive but less specific than the Pap smear. Moving to the Pap smear, we are going to say how often should a Pap smear be repeated. Every 3 years for women ages 21 to 65. Women aged 30 and older can consider Pap testing every 5 years if the procedure is combined with testing for HPV. If the patient has certain risk factors, the doctor may recommend more frequent Pap smears regardless of the age.
Now, we are going to discuss with you the management of LSIL and HSIL. SIL, squamous intraepithelial lesions, are important to manage quickly and effectively because low-grade lesions can progress to high-grade lesions, and high-grade lesions can progress to invasive cervical carcinoma. Let's start with low-grade SIL. LSIL is the same as CIN1. CIN stands for cervical intraepithelial neoplasia. Once LSIL is diagnosed using Pap smear, it's preferred to confirm the diagnosis by repeating the Pap smear and doing high-risk HPV testing. This test detects the genetic material of high-risk HPV in cervical biopsies. If the results are positive, do a colposcopy for further confirmation. Colposcopy is a medical diagnostic tool to examine illuminated magnified view of the cervix, vagina, and the vulva. If colposcopy result is positive, then the patient's condition is just monitored by doing a Pap smear every 6 months for 2 years. The first possibility is the Pap smear showing normal cells, which means a negative result. This tells that the disease has regressed and the patient's immunity was able to fight and replace the abnormal cells. The second possibility is a Pap smear continuing to show abnormal cells, which means a positive result at 12 months. This tells that the disease persists and the lesion must be removed as not to progress to HSIL and then cancer. In this case, the doctor sees if the woman wants to get pregnant or if she's still young. If so, the condition is managed by ablative treatment, which is cryotherapy or laser therapy. These techniques remove the abnormal precancerous cells. If not, then the doctor can go for excisional treatment like LEEP or conization. Let's define what is LEEP. LEEP stands for loop electrosurgical excision procedure. This procedure uses a thin electrified wire to cut out abnormal tissue. As for conization, it is also called cone biopsy. It is the removal of a large cone-shaped section of abnormal tissue for laboratory examination, as well as small amount of normal tissue. The last to define is cryotherapy. It is also called cold therapy and is done by exposing a lesion to extremely low temperatures in order to destroy this abnormal tissue. In such way, we can call it cryosurgery. The third possibility is having a Pap smear in which abnormal cells show more dysplasia, which means LSIL has progressed to HSIL. In this case, the doctor will follow the steps of HSIL management, which we are going to discuss next. Let's now discuss the management of HSIL. The first step is to confirm the diagnosis by colposcopy, through which a cervical biopsy is taken to the lab for further examination of cells. The two possible findings are CIN2 and CIN3, in which cells show more dysplasia than CIN1. If the diagnosis is CIN2, then the doctor should see the woman's state concerning her age and the intention of getting pregnant. If the woman is at reproductive age, which means she's still young, or she intends to get pregnant, the doctor has two options. Option 1 is to postpone ablative treatment and to continue monitoring the patient using colposcopy and Pap smears. If the lesion regressed, the doctor must continue to follow up the patient. Option 2 is to go directly for cryotherapy or laser therapy with follow-ups afterwards. Excisional treatment is not the one of choice because this will make a woman unable to get pregnant. If the woman is old or has no intention to get pregnant, then excisional or ablative treatment is the one of choice. Follow-ups should also be done afterwards. Now, let's see if the diagnosis is CIN3. If CIN3 is diagnosed, the doctor should directly go for ablative or excisional treatment without waiting, and follow-ups should be done afterwards. All the previously mentioned follow-ups in the management of HSIL are achieved by doing both Pap smear and high-risk HPV testing after 12 months and 24 months. If the follow-up tests are positive, then excisional or ablative treatment is repeated. If the follow-up tests are negative, then do a yearly Pap smear for 2 years. If the results are still negative, then the patient can return for routine testing, which is every 3 years.